Hi, Dr. Bethany Murray here again. So our next session will be on schizophrenia and other cognitive disorders. Let's go ahead and see if we can get this started. Okay, there we go. We'll also be talking about antipsychotic medications along with this disorder. So what is psychosis? Well, psychosis is a general term that refers to symptoms involving alterations in thought organization, sensory perception, including hallucinations, or reality orientation, delusional beliefs about the world. Psychosis is not a symptom of a particular diagnosis or disease because it can have many causes. For example, drug, head injury, ICU psychosis. But for the purposes of learning, we will be using the disease of schizophrenia as an exemplar of a symptom of psychosis. Schizophrenia is a chronic, debilitating disease that affects about 1% of the population. So of every 100 people, approximately one of them has the disease of schizophrenia. It's characterized by both psychotic symptoms and by symptoms related to poor interpersonal relationships and poor self-care. These are termed positive symptoms and negative symptoms. If you like, you can think of positive symptoms as symptoms that are added on to the individual, and negative symptoms as things that are taken away from the person. Overall, symptoms for schizophrenia may include things like hallucinations, delusions, or paranoid beliefs, strange behaviors such as rambling statements or made-up words, rapid alteration in behavior from extreme hyperactivity to stupor, an overall attitude of indifference or detachment, strange or irrational actions and movements, including agitation towards others, a persistent deterioration of personal hygiene, job performance, academic performance, and marked withdrawal from social interactions and interpersonal relationships. Historically, schizophrenia was first described in the 1800s on written record as dementia praecox. Later, psychiatrist Bloiler coined the term schizophrenia, meaning split the mind. However, this has created some confusion with the disorder of multiple personalities, which is now called dissociative identity disorder. Schizophrenia accounts for about 50% of mental health care costs and is considered to be a chronic, disabling condition. It occurs in about 1% of the population, or 1 out of approximately 100 people. Onset prior to age 12 is rare, but it does occur. Typically, onset is in late adolescence and early adulthood. And 6 up to 17% of people with a parent who have schizophrenia have an increased risk of developing it themselves. We really don't have a lot of good theories as to its cause. There are environmental theories that talk about exposure to Toxoplasma gondii or influenza during fetal development as a risk factor. There are biological theories from MRI studies in 1988 to 2000 that demonstrated deterioration of ventricles of the brain and lobe abnormalities. However, that was not a cause, that was more of an effect of the disease. And we do know that for every distinct episode of psychosis that an individual experiences, they will have brain deterioration and progressive worsening of the illness. And we have something called the dopamine hypothesis, which simply states that people with schizophrenia may have high levels of dopamine in parts of the brain. Now, we have not demonstrated that by measuring levels of dopamine, but what we do know is that all of the current antipsychotics to treat schizophrenia have as their mechanism of action dopamine antagonism. So all of the treatment drugs block dopamine in the brain. Therefore, the dopamine hypothesis says that there must be something to do with excess or imbalance of dopamine. Excessive use of drugs such as cocaine and amphetamine, which cause a significant release of dopamine in the brain, can induce psychosis. And that seems to provide some support to the dopamine hypothesis. As we learned in our discussion of neurodegenerative disorders, Parkinson's disease is a disorder of a lack of dopamine. When we give medications to treat Parkinson's disease, specifically levodopa carbidopa, we actually can induce psychosis with too much of those medications. And then sometimes drugs such as marijuana tend to counteract antipsychotic medications. Perhaps that mechanism is through dopamine alterations. What we do know is that the illness of schizophrenia improves when you reduce the transmission of dopamine in the brain, and therefore there is some association with dopamine neurotransmitters. Schizophrenia is experienced in several phases by the individual. The acute phase is when symptoms are prominent and disabling and hospitalization may be required. During a recovery or maintenance phase, symptoms may still be present, but they're less intense. The individual is more able to not pay attention to those symptoms, and clients can live independently and may even have employment or be engaged in society. And during a stable or residual phase, symptoms are in almost total remission or are very mild and chronic. Unfortunately, 1 to 2 years might elapse from the onset of first symptoms to first medical treatment because people are very resistant in general to having treatment for this disease and specifically to having this diagnosis. Again, let's revisit the two sides of symptoms of schizophrenia. Positive symptoms mean it's something that's added to the person, like hallucinations, delusions, or disordered thinking. Negative symptoms take away from the person: lack of interest, lack of motivation, lack of responsiveness to others, sometimes a decrease in speech, a decrease in motivation, apathy. Historically, our medications would only treat the positive symptoms of the disease, and the negative symptoms created the disability. As time goes on, though, newer and newer second-generation antipsychotics will address both positive and some of the negative symptoms. Sometimes positive symptoms are also called florid symptoms or psychotic symptoms. They often consist of hallucinations, delusions, bizarre, odd, or eccentric behaviors, agitation, confused or obsessive thoughts, and disorganization. Negative symptoms are actually more difficult to manage and create the disability. They consist of things like apathy or indifference to others, lack of motivation, blunted or flat emotional affect, a lack of warmth or vibrancy in life, a reduced thought activity or poverty of thoughts, a poverty of speech, a loss of pleasure in things called anhedonia, and anergia, which is a lack of energy. Negative symptoms are very hard to treat, but may respond sometimes to serotonin-based medications. So as we talk about medications, the second-generation antipsychotics have dopamine antagonism as their chief activity for the positive symptoms, but they've all added serotonin enhancing properties to try to treat the negative symptoms. Schizophrenia has several subtypes. One subtype is paranoid schizophrenia. In this subtype, the individual has predominantly suspiciousness, guardedness, and paranoid delusions. There may be auditory or visual hallucinations. The auditory hallucinations may be command in nature and tell the person to do things. There typically is not disorganized thinking. So this subtype of schizophrenia can be at high risk for safety related to violence directed toward others. Another subtype of schizophrenia is called disorganized. In this subtype, the individual has extremely disorganized thinking. They may have thoughts and speech that are incoherent or scattered. It's a highly disabling condition. Sometimes the individual loses the ability to perform basic ADLs or hygiene for themselves. Surprisingly, though, someone with disorganized schizophrenia may still have a very intact recent, intermediate, and remote memory, which does help us to differentiate this disorder from dementia. Perhaps disorganized schizophrenia is what led early psychiatrists to coin the term dementia praecox, when in fact now we know it's a very different disorder. Catatonic schizophrenia is not as common. It's characterized by extreme slowing to the point of catatonia, which sometimes can be interspersed with excitation, an activity, sort of an agitated movement, but it's purposeless. Catatonic schizophrenia may have mutism or a loss of speech, or echopraxia, which is imitating speech, or echolalia, echopraxia is imitating the behaviors of others, and echolalia is imitating the words of others. There's also some very bizarre and interesting symptoms with catatonic schizophrenia, including waxy flexibility, where a clinician could, for example, raise a patient's arm, let go, and the arm would remain raised for a long period of time. Delusions are relatively common with catatonic schizophrenia. Then finally, another type to consider is called undifferentiated schizophrenia. In this subtype, the patient does not clearly fit into one of the three previous categories, but has a blend of any or all of them. We do have some other psychotic disorders that are similar to or related to schizophrenia. And in the DSM-5, these are differentiated as separate disorders. One is schizoaffective disorder. We've talked previously about mood disorders and bipolar disorder. So you can think of schizoaffective disorder as a primary disease of schizophrenia, and superimposed on that is a mood disorder, either major depression or bipolar disorder. It can be extremely difficult to treat because sometimes you have to treat the depression, sometimes you have to treat the mania, and always you have to treat the positive symptoms and thought disorder. Schizophreniform disorder is often diagnosed on first onset. It's all of the symptoms of schizophrenia, but the duration is less than 6 months, and there's a little less impairment in the negative symptoms. It is generally thought of as a precursor to schizophrenia. In a previous talk, I presented some different personality disorders, and we should mention again, schizotypal personality disorder is an individual who has odd behavior, odd speech patterns, odd thoughts, odd perceptions, but typically it doesn't quite reach the state of a hallucination or a delusion. And so we can use this diagnosis when someone seems like they have schizophrenia, but it's at a much milder level and not responsive to medications. Delusional disorder is a specific disease that's related to having delusions only. This individual might be quite organized, functional in life, employed, but have fixed false beliefs that sometimes can be bizarre, reasonably plausible, or not true. For example, several years back, John Mellencamp, who maintains a house here in Bloomington, Indiana, had a woman who was absolutely convinced that she was his soulmate, and she was trespassing on his property and trying to climb the gate and was arrested as a result. Delusional disorders are very difficult because they typically don't respond well to medications, and individuals can end up in legal trouble if they act on some of their delusional beliefs. And then lastly, we have something called a brief psychotic disorder, which is sort of a fallback. If you have psychosis that's less than a month, and then the person returns to normal functioning, we can diagnose them with brief psychotic disorder. And there's a myriad of causes of this. It could be extreme trauma. It could be postpartum onset. It could be a substance abuse. So when we see psychosis that is very impairing, hallucinations and delusions and disorganized thinking that's very impairing, but it doesn't fit the full picture of schizophrenia, and it tends to dissipate after a month or less, then we call this a brief psychotic disorder. You can also have a substance-induced psychotic disorder when you know that the psychosis is clearly related to a substance, drug, or medication. You cannot diagnose schizophrenia until substance use is completely rolled out. Then you can have a psychotic disorder due to a medical condition. You can have psychosis with Pick's disease, which is frontal temporal lobe dementia, with renal failure, with other types of dementia, with a fever, hypoxia or lack of oxygen, hypothyroidism. Basically, any medical cause can lead a person to develop delirium, delusions, hallucinations, and psychosis. First, we need to make sure this person is medically stable before we can diagnose them with schizophrenia. And then, of course, like everything else in the DSM-5, we do have a not otherwise or an unspecified category. When someone has a psychotic disorder, but we don't really know what it is yet. So we can call it psychosis NOS until we have further workup and evaluation. At this point in life, there is no cure for schizophrenia. If someone has received this diagnosis, they must take medications for life in order to control and manage the disease. If you have subsequent episodes of agitated psychosis, then there is progressive deterioration and damage done to the brain. So our goal for treatment is to prevent recurrent episodes of psychosis. Now, this can be challenging because individuals do have autonomy and may choose not to engage in treatment. So we have to use all of our communication tools at our disposal and patient education to try to educate people as to this issue of deteriorating brain function over time and engage them in treatment. So we want to use medications consistently. Long-acting injectable medications might be helpful in that. We want to reduce the positive and negative symptoms to a level that maximizes life functioning so that individuals can go on to be happy in their home lives, interpersonal relationships, their marriages as fathers and mothers, their employment lives, and even return to school if that's what they desire. And then our other goal of treatment is to minimize side effects from medications. There are many, many side effects to antipsychotic medications, which we will be talking about. So let's talk about some of the antipsychotic medications that we use. Antipsychotic medications are the treatment of choice for schizophrenia. We divide these into two categories. We call them first generation medications and second generation medications. The first antipsychotic medication developed was Thorazine or chlorpromazine. It was developed in the 1950s. Prior to the 1950s, individuals with schizophrenia were sedated. You may remember our history of mental illness treatment lecture when we talked about using laudanum and opioid and sedatives just to control the behavior of individuals. Those drugs did nothing to actually change the hallucinations or delusions. When Thorazine or chlorpromazine came on the market in the 1950s, it was a miracle. People actually stopped having hallucinations or reduced them to a manageable level, and delusional thinking was likewise reduced. However, the first generation antipsychotics from Thorazine all the way up to haloperidol, which was in the 1980s, only treated the positive symptoms side of the equation. They all work as dopamine receptor antagonists. In the 1980s, we started to get our first second generation medications. One of the early ones of these was clozapine, which is a very special medication that we'll talk about in a few minutes. And almost all the medications that we use today are second generation. They are both dopamine antagonists and serotonin reuptake inhibitors, making more serotonin available to the brain. Now, when you're in clinical settings, you will see individuals receiving haloperidol, which is a first generation antipsychotic. It still has a lot of treatment benefit in calming agitated behavior. And I still use it in treating motor tic disorder and Tourette's syndrome, but we prefer to go with second generation antipsychotics when we can. Let's talk a little bit about what is a dopamine antagonist. So any drug that's an antagonist works to block, inhibit, or switch off a neurotransmitter or the action of a neurotransmitter on a neuron. Dopamine has 5 subtypes, D1 through 5. All of our first generation antipsychotics and most of our second generation antipsychotics actually have as their activity D2, dopamine type 2 blockade. Unfortunately, D2 blockade also results in dopamine blockage in the motor cortex and the extrapyramidal, other parts of the brain, which can affect most motor activity and cause a side effect called extrapyramidal syndrome or pseudo-Parkinsonism. In a separate slide, I will be presenting the 4 major types of involuntary movement disorders that are a result of antipsychotic medications. But we'll talk a little bit about it in this slide as well. The newer antipsychotics, the second generation, are weaker at D2 and stronger at dopamine subtype 4. In fact, clozapine, one of the reasons it's so unique and special is it's a dopamine type 4 antagonist. It does not cause the motor side effects of D2, but it does have its own unique side effects. The newer antipsychotics also enhance serotonin levels, similar to an antidepressant, and many of them are cross-approved by the FDA for bipolar disorder, particularly the depression, or as an adjunctive treatment for major depression because of those results. I do have a note at the bottom. We have one antipsychotic that is not a dopamine antagonist. It's very interesting to follow and to see going forward if we have more of these. Pimavanserin is its name. Pimavanserin was approved in 2016 specifically to treat psychosis related to Parkinson's disease. If you recall, Parkinson's disease is a disorder of insufficient dopamine. So when you use a dopamine antagonist in a person with Parkinson's disease who also has psychosis, you can further worsen the dopamine blockage and create problems with the primary neurodegenerative disorder. So pimavanserin was developed specifically for those individuals. It has as its activity all in the serotonin system as both an agonist and partial antagonist. So it'll be really interesting going forward to follow and see if we have more drugs come out on the market that are antipsychotics without dopamine antagonism. All antipsychotics have significant side effects. The most common side effects for all antipsychotic medications are on this slide in the red. So you can expect all patients to report dry mouth, constipation, increased appetite, sedation, and fine tremors. People have more or less of these side effects depending on their tolerance of the medication. I have divided up the side effects for antipsychotics categorically based on their neurotransmitter activity. So please refer back, if you have forgotten your neurotransmitters, to your neurotransmitter table that I provided you earlier. The dopamine antagonism side effects can be quite serious. They can include the extrapyramidal or pseudo-Parkinsonism syndromes, acute skeletal muscle contractions or dystonias, a phenomenon called tardive dyskinesia, akathisia or persistent restlessness, a life-threatening rare condition called neuroleptic malignant syndrome, and an elevation of prolactin in the pituitary gland because of D2 blockade in the pituitary gland. They also have more or less activity on histamine receptors and typically function as an antihistamine or antagonist of histamine. This can elevate lipid levels, increase appetite, cause weight gain that can be associated with the onset of type 2 diabetes. And lastly, antihistamine activity always causes sedation. All of the antipsychotics have some activity in the parasympathetic nervous system, cholinergic system, and the cholinergic system is divided into muscarinic and nicotinic branches. Here we're talking about the muscarinic effects. So they all behave as anticholinergics with dry mouth, constipation, and urinary hesitancy. And then lastly, they have some antagonism in the adrenergic or sympathetic nervous system. So the alpha receptor antagonism in the sympathetic nervous system can lead to blood pressure decreases and orthostatic hypotension. If you note the bar across the bottom of the table, all antipsychotics slightly lower seizure threshold. So an individual who may be prone to seizure activity or seizure disorders could have their first breakthrough seizure with an antipsychotic. Now, this does not prevent us from prescribing antipsychotics for someone who has a seizure disorder. We just need to be aware of this risk and take proper precautions, and we may need to titrate the anti-epileptic drug up higher to counteract this effect. So here are some of the different types of dopaminergic side effects and their definitions. Symptoms similar to Parkinson's disease, which we can treat with other medications. Acute muscle dystonia, which is a sudden involuntary contraction of skeletal muscles. Tardive dyskinesia, a slow, sometimes writhing involuntary movements of the muscles, often seen around the face, head, and trunk. This can be an irreversible condition, and it's difficult to respond to medication treatment. In the last 2 years, we do have 2 medications now FDA approved to treat tardive dyskinesia. Akathisia, which is a persistent need to get up and move, walk, pace, rock, It's not comfortable. It's very painful for the person, very difficult to treat, and associated with higher suicide completion rates. And then lastly, we have a rare but life-threatening disorder called neuroleptic malignant syndrome, which is characterized by severe high body temperature, skeletal muscle breakdown, acute renal failure, and hypertension, decreased consciousness. And this is considered an emergency situation. The etiology or cause of this is unknown. It is more likely to occur in a person who is older, female, who is on multiple medications, and who may be dehydrated. But other than that, there's no real way of knowing if someone will develop NMS. It's important for us as nurses, though, to recognize it when it does develop. So let's talk a minute about anticholinergic drugs. So the cholinergic nervous system is the nervous system that is managed with the neurotransmitter acetylcholine. You may recall when we talked about dementia, we treat one of the ways of slowing dementia is to increase the amount of acetylcholine in the brain. So there is a balance between the cholinergic system and the sympathetic nervous system in the brain in the disease of Parkinson's disease. Dopamine is a sympathetic nervous system neurotransmitter. Acetylcholine is a cholinergic nervous system neurotransmitter. These two are in balance with one another. When you have Parkinson's disease, the dopamine side is lower. So the acetylcholine and the cholinergic side is disproportionately higher. You treat Parkinson's disease by giving more dopamine. When you treat psychosis or schizophrenia, you artificially suppress the dopamine, and then you can induce a pseudo-Parkinsonism. So one way that you treat that, if you cannot lower the antipsychotic because of the person's illness, is you give them an anti-cholinergic drug, anti-acetylcholine, and you bring that back into balance. So the anticholinergic drugs we predominantly use are benztropine, or Cogentin is the brand name. It can be given PO or IM. Guess what? Good old diphenhydramine, the antihistamine Benadryl, has pretty significant anticholinergic activity. So we do use that PO, IM, or IV, especially in children that are having muscular side effects to antipsychotics. And then there's a third one called trihexyphenidyl or Artane that we use less frequently. For the purposes of this class, you do need to know about benztropine and diphenhydramine. Those are very important medications in psychiatry. Other medications we might sometimes use, we'll use amantadine. It's an older drug. It was originally developed as an antiviral drug. It's not an anticholinergic, but what amantadine is it actually slightly increases dopamine release and blocks dopamine reuptake. So if I go back to my table of when we suppress dopamine type 2 and get motor neuron activity or abnormal motor movements, we can actually give amantadine and increase that dopamine. The problem with giving amantadine, and the problem that I've had, is that people can become psychotic with it or manic with it. So it is not a first-line choice. For the akathisia or the restlessness, the urge to constantly move, that does not respond to anticholinergics. It responds a little bit to beta blockers, such as propranolol. It's a non-selective beta. Beta is a receptor in the sympathetic nervous system. So when we use a beta blocker, we suppress the sympathetic nervous system, which is your fight or flight or your energy nervous system. So we can help treat akathisia with a beta blocker. Sometimes people will also use benzodiazepines. It's messy to use them because of the problems with tolerance and dependency, but they can be somewhat helpful. Mostly with akathisia, you have to find another antipsychotic that is less obnoxious to the body. And then with tardive dyskinesia, the slow, more writhing, repetitive, involuntary movements that can be permanent or irreversible, we have some new treatment options. We have deutetrabenazine and we have valbenazine, Ingrezza and Austedo. Austedo is a BID dosing, Ingrezza is a once-a-day dosing. Essentially, they're chemically the same product, but they work on the presynaptic. So think back to your neuron anatomy. You have two neurons. There's a synapse beneath them. So you have a presynaptic neuron. The action potential goes down the axon to the postsynaptic neuron. So these two drugs for tardive dyskinesia work in the presynaptic neuron to release more dopamine vesicles. They're vesicle releasing. They promote the release of vesicles that contain dopamine out into the synapse. So they dump a little bit of extra dopamine out into the synapse. So that seems to help reduce some of the tardive dyskinesia symptoms. Can be quite significant for some people. So this is fairly new treatment within the last 2 years. And the practice is not as common as it will become later. So we can look forward to watching that practice as we go forward. Okay, so conventional antipsychotics are used to treat mainly the positive symptoms, as we said before. They're potent dopamine type 2 blocking agents. They have a lot of peripheral muscular, neuromuscular side effects. And the two examples that I mentioned before, which are worth keeping in mind, are haloperidol and our first one, chlorpromazine or thorazine. Okay, so what do we need to know about haloperidol? Same side effects that we've just discussed. Our second generation antipsychotics are current medications of choice for psychotic disorders. We prefer to start with the second generation because they treat both positive and negative symptoms. They block dopamine and they increase serotonin levels. How they reduce mania is unclear. How they help with negative symptoms is unclear. We just know that they do. However, they do still have dopamine blocking activity. They do still have all of the same neurological side effect risks. They also have elevated prolactin level risk, as do the first generation antipsychotics. So basically on the dopamine side of the equation, they have all of the same risks as the first generation. And because of the serotonin side of the equation and some more histamine activity, they do tend to have more sedation and weight gain overall. Our landmark second generation antipsychotic is a drug called clozapine. Clozapine targets dopamine subtype 4, not 2, which has almost no neuromuscular side effects. In fact, the most significant side effects of clozapine are sedation, weight gain, and excessive drooling, which is kind of an interesting side effect. However, when clozapine was first developed on the market and in its research trials in Europe, there were cases of individuals who died of secondary infections. Turns out in susceptible persons, clozapine can suppress white blood cell counts, specifically neutrophil counts. And people then are susceptible to secondary infections, which can be life-threatening. Because of that, the United States FDA would not approve clozapine for schizophrenia. The American Psychiatric Association countered that, talking about what a great product it is. It really reversed both positive and negative symptoms with few side effects. So the FDA did relent, but they said for the life of the person, while they're taking clozapine, they must have white blood cell counts, specifically neutrophil counts, done. Now, when this drug first came on the market, it was white blood cell count drawn weekly for life. Now, after about 20 years of this, the APA went back to the Food and Drug Administration and said, come on, we don't have that many demonstrated cases of problems. We have a protocol in place. If we're monitoring and the neutrophil count starts to drop, we have a protocol for reducing the dose or holding the dose. So the FDA did approve that clozapine can now be administered with weekly blood draw for the first 6 months that it's prescribed, then biweekly blood draw for another 6 months, and then once a month for life. So it's a great drug, but it's still not a super popular or well-known drug because of the extent of blood draws that have to be performed. So I want to mention another second generation antipsychotic called olanzapine. It's very commonly used. It's very effective for bipolar disorder. It's pretty commonly used in children. It is a dopamine type 2 antagonist, but it's a little bit weaker at the D2 receptor sites, which means that it's a little bit, it has an improved side effect profile in terms of neuromuscular side effects. Our significant problem with olanzapine is appetite and weight gain. So we do have to monitor weight monthly and watch A1C and lipid levels because of this side effect. So people that take any antipsychotic, but specifically olanzapine, can develop something called metabolic syndrome, where they have increased appetite, weight gain, hyperlipidemia, and tiredness. And these side effects will predispose a person to obesity, type 2 diabetes, hypertension, and heart disease. This can contribute to the phenomenon of early death in chronically mentally ill individuals. I want to also mention the drug risperidone. Again, it's a second-generation antipsychotic. It comes in pills, liquids, and long-acting injections. It's very commonly prescribed in pediatrics. It actually has an indication for mood swings, irritability, and aggression in autism. So you're going to see risperidone prescribed quite a bit, all the same precautions. It does cause weight gain. It does have more D2 blockade, D2 antagonism, so there is more risk for neuromuscular side effects and for akathisia. Risperidone has also been implicated with a little bit higher levels of hyperprolactinemia or high prolactin levels that are artificially induced by antipsychotics. Clinically, this looks like breast tissue enlargement, galactorrhea or breast milk production, and decreased menstruation. The first two symptoms can actually occur in men as well as women. So if these symptoms are presenting, we draw a prolactin level. If the prolactin level is high, then we do want to titrate or change the antipsychotic. We may want to refer the patient for an MRI just to make sure they don't have a primary pituitary gland tumor. What happens if someone maintains a high prolactin level over time? They start to have difficulties with alkaline phosphatase and vitamin D, which affects bone mineralization, and they can actually develop osteoporosis from having this elevated prolactin over a long period of time. So here's some of the second-generation antipsychotics that we commonly prescribe. So we have risperidone, paliperidone, ziprasidone, iloperidone, lumateperone. You can see these are often commonly grouped under the category of dones. Then we have the penes, clozapine, olanzapine, quetiapine, cariprazine, acenapine. Okay, so in practice, if someone is treatment resistant to a drug, say risperidone, you may add one of the penes to their profile. You would never want to give them two within the same category because it's basically you're giving them two of the same type of drug. But we can augment one side of the category with the other side. And then we have aripiprazole, which is a new category. It's still a dopamine antagonist. Some clinicians think of it as a third-generation antipsychotic because it does have some partial agonist, partial antagonist activity and serotonin activity. But essentially, it behaves the same as all of the other second-generation antipsychotics with the same neuromuscular side effects, sedation, weight gain, etc. Some antipsychotics are available in long-acting injections. These are very good for patients who are disorganized or patients who are court-ordered and maybe are not adherent to taking medications. Surprisingly, a great number of patients voluntarily prefer to get an injection every 2 weeks, every month, every 2 months, or even every 3 months, as opposed to having to remember to take pills every day. Okay, so let's look at this case study. A 22-year-old man has been on haloperidol 10 milligrams BID for 2 weeks for schizophrenia. During a follow-up assessment, the nurse notes the patient keeps rubbing his neck and talking about neck spasms. So what would be your initial action? What's the potential cause of this sore neck, given the information we've just had? What would be a possible medical treatment for this problem? And what kind of teaching might we do with this patient? So the patient is exhibiting signs of a side effect called acute dystonia, which is a skeletal muscle contraction. Initially, the nurse would assess the patient to ensure that he had not sustained a recent neck injury or trauma. If the neck spasm started spontaneously after starting the antipsychotic, then we're going to suspect this is an acute dystonia. We will treat this with an anticholinergic medication. We might start with diphenhydramine, or we might just go ahead with benztropine. Most likely, we would give him an injection. We could give him oral medication if it's not terribly uncomfortable for him. But if it's extremely contracted and spastic, then we would give him an IM. Then the patient or caregiver should be taught to recognize when these symptoms occur at home. They might be able to have some PRN, benztropine, or diphenhydramine to use at home, and when they should seek out medical evaluation. Okay, I know that this was a lot. It's a big disorder. It's a big part of psychiatric mental health nursing. The medications are significant, and we'll be talking about them again in other settings. And so I encourage you to email me or contact me with any questions that you might have on these medications or on this disorder of schizophrenia. And I thank you very much for your attention. Bye.